Hello guys, this is the ASMRMedic. I hope you're well. Today we're going to be going through the standard cardiovascular examination that you would be expected to perform in an OSCE testing or examination situation. I did a little caveat at the start of the first one of these I did on the cranial nerve examination. I won't go through the same thing again. An OSCE is essentially the standard testing or examination for clinical examinations. I know that we do this in medicine. I think they do similar things in things like in nursing courses, in midwifery, other healthcare professions. So let's just jump straight into it. We'll have a little look at the table of contents first. So as always, you have your introduction and general inspection, which are very similar regardless of the clinical examination you're undertaking. We then look at the hands, the pulses, the jugular venous pressure, the JVP, the face, a closer inspection of the chest, and then we palpate and auscultate. Again, this is very similar to respiratory examinations. Then, as always, you complete the examination and the steps that you do there. So, let's have a little read of this little introduction. So, cardiovascular examination frequently appears in OSCEs, and that's true. It's a really common thing. You'll be expected to pick up the relevant clinical signs using your examination skills. This cardiovascular examination OSCE guide provides a clear set step-by-step approach to examining the cardiovascular system with an included video demonstration which we're not going to go through. But I will link this page in the description for your own perusal. So the standard introduction. First of all, dramatically wash your hands, make sure the inspector sees and make sure the patient sees as well. Very important that they see. It's all about kind of making them feel comfortable. Then you introduce yourself, say, hi, my name is the ASMRMedic. I wouldn't say that, I would usually give my normal name, my actual name. Just introduce yourself generally. So I'm a second year medical student, and then you want to confirm their details. So can I just quickly take your name and date of birth? And then you explain the examination in just kind of simple terms. So in terms of this sort of thing, you'll be looking at, I said, the hands, pulses and stuff. So to say, I'm going to take a quick look at your hands, your face, have a little feel and listen to different areas. And that's just about it really. So just something simple, something quick, and then gain consent. Now, the reason we can gain consent for pretty much everything we're going to do from the start is because it's all non-invasive treatments, non-invasive examinations, and so there's not really any risk of pain or anything like that to the patient, so we can gain a general consent at the start and not have to constantly regain consent as we go. Then what you do is you want to position the patient at a 45-degree angle, usually on the hospital bed that they're in, with their chest exposed. So you need to ask them, would you mind exposing your chest for me, so I can begin the examination. And then you want to ask them if the patient is currently in any pain or discomfort. If they are, as I said in the last video, you want to ask them more probing questions to really nail down what they mean by that. Actually, assuming that you've not watched the last video, I'm going to run through that again. So if they do say that they're in pain, if not, then just carry on. But if they do say they're in pain or discomfort, you want to ask them what they mean by that, what sort of pain, where is the pain, and if they when they tell you where it is, ask them, can they characterise it a bit more for you? So is it like a dull aching pain? Is it a sort of sudden stabbing or shooting pain? Is it a radiating pain? That sort of thing. Ask them more general questions about the pain, such as, what do you think brought on the pain? Have you had this pain before? What helps relieve the pain? What makes the pain worse? That sort of thing. What exacerbates it? And then you want to begin your general inspection. This is called sort of the bedside routine, I suppose. And so it says bedside, so treatments or adjuncts. So GTN spray, that's to do with angina. O2, are they on oxygen? Medication, you want to look at the types of medication. Does that give you any indication of what disease they might have? Are there any mobility aids, sort of like, are there any walking aids, things like this? Loads of things. Look around the bed, see if you can see anything, and what can you really take away from that? What can you, what does that suggest about the patient, about the disease they potentially have, pathologies that they're suffering from, before you've even talked to them? So they have malar flash, which is a plum red discoloration of the cheeks, and that suggests mitral stenosis. Then obviously they've exposed their chest, so you can inspect their chest. Do they have any scars or visible pulsations? And this can suggest lots of different tests and procedures that have been done to them. remember to look underneath the arm for thoracotomy scars, beg your pardon, and for any small scars from minimal invasive surgery. And lots of these different scars indicate different procedures and that sort of stuff. And then you want to inspect their legs. You want to check for scars of the saphenous vein harvest, which is known, which comes from a cabbage or CAGP. You'll look for peripheral edema, so that's sort of pitting of the legs. Just at the moment you're just inspecting that you're not touching. And you want to look for any missing limbs or toes. These things you might think, these look really obvious. So obviously I'm going to see if there's a limb or toe, but you need to note down in your head. And then you need to do an end of the bed inspection, so this is also included, but that's looking at them and seeing if you can see any sort of signs of discomfort or unrest. So are they short of breath? Are they cyanosed? Cyanose is blue lips, which is central cyanosis, or blue hands, fingers, sort of very, very pale or sort of light blue. That's peripheral cyanosis. Have they got pallor, or do they have any edema? Usually in the lower legs. Then you want to look at their hands. We're moving on to touching and looking at the patient now. So ask for them to place their hands out in front of them, hands out with palms facing downwards. You want to look for splinter hemorrhages. These are reddish brown streaks on the nail bed, which suggest bacterioendocarditis, which is very bad. You look for finger clubbing, and this is a typical sign of pathology. It actually goes with a lot of things, including some respiratory issues. So finger clubbing asks the patient to place the nails of their index fingers back to back. So kind of putting them so their fingers are facing downwards. Imagine they're making a heart shape with their hand, with their index fingers, and have a look. In a healthy individual, you should observe a small kind of diamond-shaped window where their nails touch the sort of nail bed. That's known as Shamroth's window. If the fingers are clubbed, there will be no window, and they'll just press neatly together. You won't see any gap between the fingers. Finger clubbing has a number of causes, such as infective endocarditis again, and cyanotic congenital heart disease. Then you want to ask them to turn their hands over. Look at the colour of their hands. If it's a dusky bluish discoloration, that suggests peripheral cyanosis, which is suggestive of hypoxia. You want to feel the temperature of their upper arm, of their lower arm, and their hands. Cool periphery suggests poor cardiac output or hypovolemia. Are they sweaty or clammy? This can be associated with acute coronary syndrome. Do they have any Janeway lesions? Does a non-tender maculopapular erythematous palm pulp lesion? You have to look that up for yourself to see what they look like. It suggests of bacterioendocarditis. Have they got any Osler's nodes? Tender red nodules on the fingers, finger pops, or thenar eminence, infective carditis. Are there any? And then it's more sort of general signs. So, do they have tar staining, which is sort of like a dark yellow staining of the fingers? It suggests they're a smoker, which is obviously a risk factor of cardiovascular disease. Have they got any xanthomata, sort of a raised yellow lesion on the hands, often noted at the tendons of the wrists, which is suggestive of hyperlipidemia or hypercholesterolemia, and that's obviously again a risk factor for cardiovascular disease. And then you want to check the capillary refill time. The normal time for this is just under 2 seconds. So you press their nail bed and the underside of their finger together, and then you release. And how long does it take for the capillaries to refill and sort of the colour to return in the area that you pressed? If it's longer than 2 seconds, this may suggest hypovolemia, I beg pardon. Okay, so a little look at the pictures maybe. So this is the nail inspection, so this is splinter hemorrhages. And this is what we mean by the clubbing. So this is the little Shamroth's window in the middle, that kind of diamond shape, so you put them together in that kind of shape. And this is the clubbing sort of thing that you may see. And then we have Janeway lesions and tar smoking. And this is the capillary refill time. Okay, now you want to check the pulses. So if you start off with the radial pulse, which is located, if you put your kind of 2 fingers and put it sort of at the wrist and just below the thumb, sort of the bed of the thumb at the wrist, that's usually the best place to find it. Usually more, distal, not distal, opposite of medial, usually more lateral across the arm. want to assess that for the rate and rhythm, essentially. Then you want to look for the radial delay. So palpate both radial pulses at the same time, so on either arm. They should occur at the same time in a healthy adult. Radial delay can be associated with subclavian artery stenosis, compression by cervical rib usually, or aortic dissection. You want to assess for collapsing pulse associated with aortic regurgitation. Firstly, ensure the patient has no shoulder pain. Palpate the radial pulse with your hand wrapped around the wrist. Raise the arm above the head briskly, so nice and quick. Feel for a tapping impulse through the muscle bulk of the arm as the blood empties from the arm very quickly in diastole, resulting in a palpable sensation. This is known as the water hammer pulse and can occur in normal physiological states during fever or pregnancy, or more importantly in this case, cardiac lesions. So that's aortic regurgitation. I think that stands for PDA. Pulmonary. I don't know. You have to look that up. I'm afraid. Sorry. Or high output states as anemia, or atrioventricular fistula, or thyrotoxetosis. I think. It's no thyrotoxosis, of course. Apologies. And you also want to check their brachial pulse. So that's assessing the volume and character of the brachial pulse. And the brachial pulse is felt in the elbow joint, so inside the joint of the elbow, on the other side of the elbow, and it's best to feel that if you press sort of medially and into the bicep muscle, sort of pressing the vessel. Imagine you're pressing the vessel against the muscle or the bone, I suppose, as well, and that kind of usually means you can feel it a little bit easier. Then you want to check for blood pressure, so you want to measure the blood pressure and note for any abnormalities, so obviously hypertension or hypotension, and you want to, it says assess for narrow pulse pressure, which can be associated with aortic stenosis. You want to check for the wide pulse pressure, which is associated with aortic regurgitation. But I mean, I've not even heard of those things, so not the diseases, but the narrow and wide pulse pressures. So as they say, it's quite unlikely that you'll be asked to do those. But as it says, the things that you might not be asked to do, it's usually good to say that you would have done it in the ideal situation. And then you want to check for the carotid pulse, which is in the neck. So I don't know if it might show you here. There you go. So you're kind of, again, you just look for you just kind of put it on the inside of the neck, and you should be able to feel it quite clearly. Again, assess the character and volume. It's a slow rising character, as you might find in aortic stenosis. And then, as it says, it's usually quite good to auscultate, which is using the stethoscope and the carotid artery for a bruit before palpating. Yes, I actually forgot about this, because in some people, especially those who are at high risk factor, stressful palpation could actually dislodge some kind of plaque, which, in really bad situations could lead to a stroke. Actually, so it's in a very vulnerable position if you dislodge a plaque there. However, if you perform a carotid auscultation at this point, remember that the bruit may actually be a radiating murmur. Moving on to the jugular venous pressure, the JVP, you want to ensure that the patient is positioned at a 45-degree angle like we did at the start. You want to ask the patient to turn their head away from you, and usually to sort of a 30-degree angle as well, which doesn't say there, so kind of you want to turn away and slightly up as well. Usually to the right side, I believe. So you then want to observe the neck for the JVP, located in line with the sternocleidomastoid muscle, which is very clear, pops out of the neck quite nicely. Then you want to measure the JVP. This is done in a number of centimetres from the sternal angle to the upper border of the pulsation. Now, a raised JVP can indicate a fluid overload, or right ventricular failure, or tricuspid regurgitation. There's a couple of other things as well, actually. Then you want to test the hepatojugular reflex. It says in red there, because I was about to say as a caveat that usually you don't perform this in OSCE because it's quite uncomfortable. Usually people who have it performed on them find it quite painful. But again, just as I said, the examiner will often prevent you from performing it. But again, mention it. That's the important thing. So you want to apply pressure to the liver, which in itself is quite painful, and you want to, and then usually quite quickly. So you want to kind of press in on the liver quite firmly, and observe the JVP rise in the neck. So again, the patient has their head turned away from you, so you can observe it quite nicely. In healthy individuals, this should last no longer than 1 to 2 cardiac cycles. Then it should fall back down the JVP. If the rise in JVP is sustained and equal to or greater than 4 centimeters, then this is a positive result. A positive hepatojugular reflex, or reflux, actually I said reflex, reflux, and that is important, is a sign suggestive of right-sided heart failure or tricuspid regurgitation. Because essentially what you're doing is when you're pushing in on the liver, you're actually and this is why it's uncomfortable, is you're squeezing the blood out of the liver, and it's actually directed straight up into your head, straight up into your neck. So you can understand why that would be quite uncomfortable. So this is what we're doing now. The hand just there, down at the bottom, is pushing it down. So we move on to the face. Starting with the eyes, we're looking for conjunctival pallor, which is suggestive of anemia. You want to ask the patient to gently pull down their lower eyelid, and you're looking, and as they look up, you can usually see some form of conjunctival pallor in anemic patients. You're looking for corneal arcus and xanthelasma, which are related. Corneal arcus is, as the name suggests, it's kind of this yellow-grey ring which goes around the iris of the eye, and xanthelasma is a yellow raised lesions around the outside of the eye that are really quite distinctive. They're both suggestive of hypercholesterolemia, which is raised cholesterol in the blood. Usually it's familial. It's usually a congenital condition, which is a risk factor for lots of cardiac problems, usually vascular. Then you want to look at the mouth. And this is the main thing is central cyanosis. So if they've got blue discoloration of the lips or underneath the tongue, so you want to look at the lips, ask them to open their mouth and raise their tongue to the roof of their mouth, looking for kind of a bluish cyanosis. Then you want to look for angular stomatitis, which is inflammation of the corners of the mouth, which suggests iron deficiency. And then you want to look for high arched palate, so that's suggestive of Marfan syndrome, which is quite an increased risk of aortic aneurysm of dissection. Both of which are very, very bad. Marfan syndrome, you should have other suggestions that they've got this syndrome otherwise. But anyway, moving on finally to dental hygiene, which is an important considered source. It's an important source of potentially developing infective endocarditis. So that's one of those interesting ones that you might not think about actually. Then you want to look for chest wall deformities or visible pulsations. Let's move on to palpation. It's an important part of the examination. Firstly, you want to look for the apex beat, and this is located in the 5th intercostal space. It says at the mid-clavicular line, which is true, but and you're looking for sort of displacement of this, which it says later. So you want to palpate the apex beat with your fingers placed horizontally across the chest. Any lateral, so further across, away from the midline, displacement suggests cardiomegaly, sort of like hypertrophy of the heart. You want to look for heaves. A parasternal heave is a precordial impulse that can be palpated. Parasternal heaves are present in patients with right ventricular hypertrophy. Place the heel of your hand parallel to the sternal edge, fingers vertical, to palpate for heaves. If heaves are present, you should feel the heel of your hand being lifted with each systole. Then you want to check for thrills. A thrill is a palpable vibration caused by turbulent blood flow through the heart valve. The thrill is palpable murmur. You should assess for a thrill across each of the heart valves in turn. To do this, place your hand horizontally across the chest with the flats of your fingers and palm over the valve to be assessed. And there are a number of specific positions that you can do that, and you should maybe have a look at that yourself, I suppose. Then finally you want to move on to auscultation, which is the use of your stethoscope. So you're auscultating the 4 valves of the heart. A systematic routine will ensure that you remember all the steps whilst giving you several chances to listen to each valve area. Your routine should avoid excess repetition, whilst each step should build upon the information gathered by the previous steps. So this is quite a nice little breakdown of the best way to kind of go through this. So firstly, you want to palpate the carotid pulse to determine the first heart sound, which is in the neck. Secondly, you want to auscultate upwards through the heart, through the valves areas, using the diaphragm of the stethoscope. Firstly, start with the mitral valve, which is in the fifth intercostal space, the midclaviculine, and we may know this is also the apex beat, but you check there for the mitral valve. Next is the tricuspid valve, which is about to say on the other side, I think it is, but you're checking it at the fourth or fifth intercostal space, lower left sternal edge. Next is the pulmonary valve, the second intercostal space on the left sternal edge. And finally the aortic valve, the second intercostal space of the right sternal edge. Repeat auscultation across the four valves with the bell of the stethoscope. Fourth, auscultate the carotid arteries with the patient holding their breath to check for radiation of an aortic stenosis murmur. This is known as the accentuation maneuver. Sit the patient forwards and auscultate over the aortic area during expiration to listen for the murmur of aortic regurgitation. This is known as an accentuation maneuver. And then lastly, roll the patient over onto their left side and listen to the mitral area with the bell during expiration for mitral murmurs, regurgitation and stenosis. Okay, and that's the end of the cardiology examination for your OSCEs in terms of actually physically doing things like that clinically. And then what you need to do is you need to complete your examination, and you do this firstly. Oh, it's got a few more things. I didn't really realize you had to do this, but firstly, so on completion of the examination, you need to auscultate the lung bases. You're checking for crackles, which is suggestive of pulmonary edema, and these are things that you would also cover in your pulmonary tests as well, your pulmonary OSCE. Respiratory OSCE, I suppose, is the best way to put it. You want to consider if you do find crackles, this is suggestive of left ventricular failure. And then you want to consider chronic lung diseases if the patient has no other signs of fluid overload. So that's stuff like pulmonary fibrosis. You also want to check sacral edema and pedal edema. So that's the sacral edema is at the bottom of the spine at the back. And these also indicate right ventricular failure. And then, once again, as always, thank the patient for their time, wish them well, wash your hands nice and clearly, and summarise all of the findings that you've gathered to the assessor. And then, in terms of suggesting further assessments or investigation, usually you have to provide 3. They've given you 5 things that you might want to use depending on the results that you've got from the findings you've got from the examination. So 5 of these they put down is potentially a full peripheral vascular examination, a 12-lead ECG. So if you're thinking about arrhythmias or myocardial ischemia, 12-lead ECGs usually you'll be suggesting that. A dipstick urine test, so that's looking for proteinuria or hematuria. It says that it suggests hypertension. You may also want to do a bedside capillary blood glucose test, which is done regularly for people with diabetes, or perform a fundoscopy. So that was reviewed by Dr. Matthew Jackson. It was written by Dr. Lewis Potter. So guys, I hope you found that useful. I hope you found it informative. Thank you very much for watching, and I hope you have a lovely rest of